Hello, everyone, and thank you so much for joining us today to hear about the Infection Management Coalition, or IMC. We're hopeful, and I think looking around, that this session will stimulate lots of conversation and sharing of best practice. I'm Lee Durnall. I'm from Menarini. Just out of interest, hands up if you've heard of Menarini. Okay, thank you very much. So Menarini, we're a privately owned Italian company. We have an office in Buckinghamshire. I work in the medical affairs team, and I'm the public affairs lead for Menarini. And one of the things that I try and do is to raise awareness, as well as of the Infection Management Coalition. So my fellow speakers here as well, and we are going to introduce the IMC to you. So what you can see behind me is the Jubilee Room at Westminster Hall, and some of the members of the coalition there as well. COVID-19 showed us what the terrible effects an infectious disease can have when there are no preventive or treatment options. We must consider a more holistic approach to infection management to protect society, our healthcare system, and economy. We know about the challenges in infection management. We know about the impact of antimicrobial resistance. It's felt across the world. Common infections become, sadly, severe infections, sepsis, for example. And in the UK, and I'll talk about this a little bit later, steps are being taken to boost investments in research and development, looking at bringing new antimicrobials to be available to the NHS and also to patients. So the Infection Management Coalition was born, through a shared belief. We believe we radically need to change the way in how we manage infection. We're a coalition of charities, life sciences industry. We have quite a wide coalition of people, life science organizations as well. And the IMC spans prevention and surveillance right through to support for people who have suffered from infectious diseases. And in early 2022, we launched our white paper. It details a number of recommendations, and bedtime reading, maybe I'd urge you to have a little look at the white paper. In fact, I think there are some copies in the room as well. And last summer, which is what this photograph is, last summer on the hottest day of the year, we held a parliamentary event, and we secured support from national and international policymakers, including World Health Organization, Professor Sir Chris Whitty, the Right Honourable Jeremy Hunt MP, and key infection decision makers. In fact, that pledge board you can see there at the front, ably supported by my fellow speaker, Doris Ann. So our white paper recommends equal consideration of 4 key pillars. Number 1, outbreak and pandemic preparedness. It includes global system surveillance and a renewed focus on the research and development of new antibiotics. Pillar 2, infection prevention. It includes, now this list is not exhaustive, but it includes screening, building design, systems design, and I could go on, there's a long list. Number 3, rapid recognition, diagnosis and treatment of time-critical infections through public awareness, improved diagnosis and treatment, through training and education, healthcare systems, and pathway design. And the last but not least, 4th pillar, antimicrobial stewardship, including streamlined therapeutic pipeline, clear deployment of effective antimicrobial prescribing, rapid diagnostics, including identifying any resistance mechanisms. There's a long list, a good long list. Patient access, very important. Public awareness, and of course the media has its part to play. The global effort to tackle COVID-19 resulted in an unprecedented collaboration and partnerships across government, healthcare industry, and the scientific community. Sadly, infection is common, and effective infection management must involve all stakeholders, from healthcare professionals, health system leaders, the life science industry, and also charities, of which the IMC are a representation. As a coalition, we aim to break down silos. We meet on a regular basis. We meet every 2 weeks. We talk about strategic direction, sharing best practice, how we will engage with stakeholders, with you, and also what best practice we can share. Integrated care systems. I think the integrated pathway, or the ICSs, lends itself to infection prevention and management. Undoubtedly, the move to, but it also offers an invaluable opportunity to push forward the transformation in the field of infection management. Every ICS will have its own infection management strategy. What we have to be careful of is that infection management isn't deprioritized and viewed as a long-term threat, as opposed to the current one that it actually is. And there's lots of competing elements there, financial and workshop pressures on the system. So finally from me, you've probably heard or read in the Financial Times, I've done a piece on something called the Netflix subscription model. It has different terms. I don't know whether anybody's heard about the novel way in which antibiotics might be reimbursed in the future. So just a very potted history here. It's also the medical director of the ABPI did an interview on Radio 4 quite recently. So government and industry are working really hard to ensure the development of future antibiotics. I mean, imagine a world without effective antibiotics. It's a novel reimbursement scheme. It was commissioned by NICE, NHS England, and the Department of Health and Social Care. Instead of being reimbursed for how many boxes of an antibiotic are sold, the value is actually delinked from the volume used, and it's tethered to the value that an antimicrobial can bring to the NHS, and most importantly to the patient. It's more in line with antimicrobial stewardship. So by applying an appropriate value to novel therapeutics that can handle antimicrobial resistance, the global investment in research and development production of antimicrobials can become economically viable for industry again, at the same time guaranteeing society access to an innovative pipeline of treatments to address antimicrobial resistance. However, this needs to be matched by equal willingness to innovate in the funding of diagnostics.
Good afternoon, everyone. As you saw from the introductory slide, I'm Jonathan Pearce. I'm the CEO of Antibiotic Research UK. And we're a charity that funds and carries out research into antibiotic resistance. We raise awareness, and we also work with patients who are affected by antibiotic-resistant infections. And we're very proud to be part of the IMC and see it as an important vehicle for raising awareness, bringing about change in the field of infection prevention and control, and also AMR. I've been asked to talk a little bit about one of the themes in the white paper, about data, essentially. And I know sometimes data gets a bad name, bad reputation. It's seen as a bit boring, subject for geeks, that sort of thing. But data is massively important, and it can't be underestimated, the importance and significance of having comprehensive data on infection management, infection prevention, infectious diseases, every aspect of it. Because data drives change. It gives us the tools, the evidence to know whether we're doing things correctly, incorrectly, whether we need to change or improve things. It also helps us to analyse what we're doing and learn from things, learn from mistakes, learn from opportunities and so on. It also gives us the opportunity to really be effective about what we do, manage budgets and so on. So it's vitally important to every aspect of what we do. Unfortunately, the system for data that we have at the moment isn't robust enough, doesn't give us the tools and the equipment, the analysis to really improve the world of infection prevention and control in the way that we would like. And it means that it doesn't give us the stories, the narrative that we need to bring about change and drive improvement. But there are, I should have moved on, having said it was so simple to use this clicker. There are examples around us of where this works well. You know, even within the field we're talking about, there's the BSAC UK Antimicrobial Registry, which is starting to collect data on the use of antimicrobial agents that is used by clinicians, by researchers, and by industry to understand what's effective and not effective. But things like that need to be rolled out much more widely. You can see in other areas of health, cancer is always a very good example. There's lots of systems there to collect the data that informs practice, informs policy, helps us better understand what we're doing. We've got here one example, the Cancer Patient Experience Survey, which goes out, it certainly used to go out every year, it may not be quite every year now, collects a massive amount of granular data on the patient experience that's used then by patients and also by healthcare professionals. And looking at cancer as a sort of paradigm, if you like, you can see when there was a realization that needed to change and improve, and that's still an ongoing journey, there's a massive investment in the whole data system around cancer, making sure that at the grassroots level down to cancer registries within individual hospitals and trusts, that there was systemic improvement in terms of the collection of data, the accuracy of it, the clinical review, the pipeline of data that then goes all the way through to, it was Public Health England, wasn't it, and NCRAS, but now within the UK Health Security Agency, to make sure there's a pipeline that produces dashboards that can be used to review and analyse and change and monitor and so on. So we think that sort of scale of change needs to happen with infection management and for AMR. And then also within our white paper, you see a related issue, which is obviously, behind this is a data issue as well. It's about the coding system for infection mortality coding and death certification. At the moment, it's very hard to identify, where people have been affected by, died from sepsis or from AMR-related infections. There isn't an adequate coding system to collect that and then to report on it. So that means we're making it less visible for the healthcare system, healthcare practitioners, but also less visible for people affected by it in everyday life. Certainly we see this at Antibiotic Research UK, where patients aren't aware that they're affected by an anti-AMR infection, and it certainly doesn't appear on a death certificate. So it doesn't help us build that story, build that narrative that we need to affect and improve and address something that's essentially our next and current pandemic. So we would like to see more done to improve that side of things, enhance the mechanisms to diagnose infection and then learn from that. Yeah, and I think that's probably covered that side of things. And so behind that is a way to achieve that would be reviewing the system for coding, building it in, rolling it out in terms of a new monitoring system, equipping staff within the healthcare service to understand and be trained about how that data is collected, so that we can then start to follow patients through the system as they present to the healthcare system, and they're then diagnosed and treated, and their aftercare and so on. And at the moment, we lose patients through that system, and we need essentially an ambitious, comprehensive, widely interconnected framework for data that analyses this at a granular patient level, so that we can learn from individual patient experiences, make us more aware of what's going on, so that we can improve the systems around data management for patient better and improving patient outcomes.
Good afternoon, everyone. I'm the last speaker in the session before we get on to discussion and questions and answers. I'm Doris Ann Williams. I'm Chief Executive of the British In Vitro Diagnostics Association, or BIVDA, and we're the industry body representing diagnostic manufacturers, both in the UK and also from around the world. So 240 companies specialising in diagnostic tests. Everything from advanced molecular and genomic tests right through to point of care, at which point I always used to say, such as pregnancy kits. But of course now I say, like the COVID lateral flow devices that you've all been used to using. So, like the other partners in the IMC, BIVDA and some of our members who are also part of the IMC are really delighted to be here. We feel that diagnostics doesn't always get a voice, and the information that we provide or our products provide is critical in healthcare. But an interesting fact is that the sales in the UK to the NHS of all diagnostic tests, including blood glucose strips, was 1.2 billion last year, which is a lot of money, but it equates to about the same as the spend on statins. So we do represent a great value for money for all the information we provide, and something like 85% of patient pathways involve a diagnostic or several diagnostics. So you can't manage healthcare without us. And what we really want to see is bridging, like the slide says, bridging the diagnostics and the therapeutics gap and ensure greater integration of point-of-care diagnostics along the infection pathway. So not just doing tests in hospitals, but doing them in the community as well. So diagnostic tests are critical in hospitals, not just for diagnosing, but for also ruling out causes of disease, critically for targeting treatment, and also reducing nosocomial infection by making sure that you're picking up infection around the hospital setting. And diagnostics are also important in the community. Again, diagnosing and ruling out, targeting treatment, but preventing the spread of infection, keeping people from moving around when they have got an infectious disease, keeping them at home, treating them safely. And it's an area where we could really improve greatly. The integrated care system, which Lee mentioned, we're hoping will reduce the sort of financial blocks that stop a lot of diagnostic testing in the community. And interestingly, in veterinary medicine, they do a lot of effectively point-of-care testing because the patients or the patient's owners and the patient's insurance policies pay for the testing. So they probably over-test, and they certainly over-test in America where doctor's office testing is heavily reimbursed. Excuse me. But the picture there, that's actually a veterinary diagnostic instrument because I don't want to upset any one company by using their product over another. But it just gives you an idea. These are small, easily portable pieces of equipment, and more they're being used in the community. We need to see that more in ruling out infection and using tests like CRP, which has been discussed in the Managing Deteriorating Conditions parallel conference today in this morning's session. The other part of importance in diagnostics is in their role in developing new drugs. So you really need a diagnostic tool to help establish whether a drug is working as you think it will. So we need diagnostics to identify the role of those drugs, to work in combination, and to identify the patient populations that you need to apply the drugs to. And I think that's where we're going to see more and more effective healthcare, where you're using diagnostics to actually identify patient populations and work in combination with a drug. And it probably won't be a single drug and diagnostic test pairing, but actually being much more intelligent about how we use drugs so that we're getting the right drug to the right person at the right time. And that is particularly critical in infection, where infection is time critical, and we need to get people diagnosed and treated quickly. So, as Lee said, we've got the white paper, there's copies flying around, and you can download it from the website. It's theimc.org is the address, so quite easy to remember. So really do recommend you have a good look at that.